Well, hi, everybody. Welcome. My name is Garrett Schmidt. I'm the managing editor for VBC Exhibit Hall. And I'd like to welcome you, as always, to today's live webinar with Roji Health Intelligence, which is hosting us today. And it is called Your ACO Guide to Targeting Costs with Data-Driven Strategies. This is part 3 of a 3-part series. And this is creating a strategy that works. We'll be able to, if you haven't seen the other two, don't worry, that's fine. You'll be able to jump right in, and we'll also, of course, have access that you can go back and watch the other ones as well. A few items of note before we get started. This is a traditional webinar format, meaning that you don't need to worry about muting yourself or turning off your camera or anything like that. That's been done for you, so you can just sit back and enjoy. However, we are going to have a time for Q&A towards the end of the presentation. So if you have a question at any point during the presentation, go ahead and drop that question into there's a little space in your module there for questions specifically. And we're going to get to as many as we can. We have a big presentation today. I got a little preview of it. So if we run out of time, if we're not able to get to yours, don't worry. Someone will reach out to you via email afterwards to answer your question. Finally, the session is being recorded today. So what's going to happen is about maybe an hour or so after the conclusion, you'll receive an email, and it will have a link to the recording as well as to the slides. We hope that you will review that as your own leisure and share that with colleagues and friends. We hope that you do. And without further ado, I wanted to introduce our speaker today. We have Miss Teresa Hush, and she is the CEO and co-founder of Roji Health Intelligence. So welcome, Terry.
Thank you, Garrett. It's really delightful to be here again, and we'll be wrapping up what we've presented in the last couple of sessions. So let me get about that right away. First, a little bit about Roji Health Intelligence. We are in the space of value-based care technology for providers, and we do both quality and cost performance. So we're heavily into the data and doing exactly what we're presenting here today. Before I get started, I want to find out a little bit about you and see where you are in the data spectrum. We've talked a lot about data in the first 2 parts of the webinar series. And the question I have today is how data abundant you are, actually. And you can see the convention of many data points here, all golden retrievers convening in Scotland last year. So how data abundant are you? Here are your choices for your polling question. Yes, our diet is claims data. That's how we consume data. B, yes, we fish both claims and clinical or EHR data. Or C, we pool claims, EHR, and other data into a value-based care database.
Okay, we're going to go ahead and pull that poll up here. And so you should see that now on your screen. And this is anonymous. So go ahead and don't worry, you can answer this question. And we're going to share the results here with everybody momentarily when all the results come in. And you'll get a chance to see kind of where you stack among your colleagues. And again, this is a choose one that most applies. Are you data abundant? Let's say we've got most of the results in, but we're going to give it about another 5 long seconds, and then we'll close it down and share the results here. Okay, I think most of the results have come in, and we're going to shut it down in 5, 4, 3, 2, and 1. Here we go. Okay, so Terry, I'm going to read out the results to you here. So again, the question is, are you data abundant? And yes, our diet is claims data. We have 7%. Yes, we fish both claims and clinical EHR data is 43%. Yes, we pool claims, EHR, and other data into value-based care. That's 50%.
Great. That's great. That's going to be really helpful for us to define exactly what you're doing with all of that data that you have now pooled into various databases. And in fact, today's focus is going to be a short review of what we've done, talked about recently, about the total cost of care and the total per capita cost, and then how you go about synthesizing your strategy for cost control that achieves a reduction in the total per capita cost, is data driven, so you're going to be using a lot of that data, is both effective and efficient. I think that's really important because data is and can be extremely expensive. So you want to be able to use it wisely, and you want to be able to multi-purpose your data frequently. It has a reasonable cost, and last but not least, it's acceptable to physicians. So you should have an easy go of this. Feel the breeze. Review a little bit about what we talked about in part one. First of all, reducing the total cost of care is a goal. It can't be actionable. Why? Because it's too broad. In order to receive the goals, you have to target specific areas of cost, and we discussed how you might go about that. What data do you have to aim at those targets? If your data is limited, for the 7% who are using claims, that is going to limit the capabilities of what you actually can do. But we found some workarounds in part one as well. And if you have a lot of data, you'll be able to go at a lot of different initiatives. Another thing we discussed in part one is if you have just APP reporting data, you can pursue the clinical objectives that are related to those three measures because you'll have the data on the clinical data on the patients in your Medicare program at least, and possibly of all patients. So with that data, you can target interventions for patients with diabetes, you can target interventions for patients with hypertension, and you can do follow-up with patients who have been failing depression screen but don't have a plan of care. So those three things can get you started on an overall program of cost control. On the second webinar, we went after the scenario of you having additional data, so aggregated EHR data plus claims. So with that kind of portfolio, you can start pursuing predictive risk assessment. So you can get off the issue of having limited retrospective data on your admissions and your ER as your only tool to be able to identify who is more severe in exacerbations or problems with risk. You can find those early in your EHR data and match them with your claims to see what's happened to them. On the preventive or early diagnosis of various conditions, you can go forward like chronic kidney disease. You can start to develop algorithms that help you identify where patients are in the spectrum before they're in real trouble. You can look at procedure and treatment cost variation. You can look at population-based interventions for patients progressing in severity of their disease. And you can begin to do specialty care collaboration because you are gathering a lot of clinical data that is really focused on specialty care, not just primary care. We also talked about two ways or two paths for you to reduce costs with a clinical focus. First, the clinical quality path, which allows you to address conditions using a clinical improvement approach and reducing utilization. And secondly, a cost variation path that allows you to map the cost of different procedures or specialty treatments along a spectrum so that you can start to work with specialists on reducing variation and addressing the underlying issues that are causing cost to go out of bounds. So those are two very different approaches. One is more clinically focused, but the other one has a lot of clinical components in it. And we're going to get into much deeper ground on that today. So starting for today, it's just easy, right? You just pick out a few of these projects and your total per capita cost or your total cost of care goes down, right? Well, not exactly. What you really need is a much larger program that focuses on multiple initiatives. And the question is how you go about it. So this is a map. If you do dog agility, as I do, you will see that this map is an extremely complicated route of obstacles. You have to lead your dog through this path. It's not that much different than what you're going to be doing when you do a strategic map for cost control. Why? Because there are frequent changes in directions, frequent changes in criteria. You have to communicate all along the path. You will need to effectively deploy your resources. In this case, it's your dog, but in real life, it's your staff, your resources. As an ACO, you're not in physician leadership, so a lot of those clinical resources are one step or two steps even removed from the organization. So you'll need to actually enlist their interest in these initiatives. And besides that, everybody's revenues are at stake. So it requires a buy-in to what your overall design of your initiatives are. If you don't have a multiple initiative map where people can see which way it's going, it's very hard to see the big picture. From a flat ground, everything really looks kind of similar. It looks like that hoop is sitting right on top of this bar and that there aren't a whole lot of other obstacles on the path. And that may not be the direction that your course is supposed to take you, but that's the direction that you see. Information is coming in little bits, just like your car nav system, where you're infuriated because you can't see exactly which direction the nav system is taking you. And your stakeholders and staff become very confused about a process in which they can't see what the end game is, so they just check out. Your strategic map needs to be your overarching design for everything that is going to be involved in your cost control initiatives. Your goals, how you'll achieve them, your objectives, how you plan your data aggregation is a big one. Are you going to have the data that you need to accomplish each of the goals and objectives you've laid out? The concepts for your direction that initiatives are going to go, where you will start, that's a big thing. Are you going to be starting with primary care or specialties, population, with overall questions? Your time frame for implementation, how fast and furious can you build this overarching design? And then who's going to be involved in managing the entire initiatives and operating them on a day-to-day basis as well. So I'm going to go through 5 tips right now. They're all jumps. They're hurdles for you to cross. First is start with your most important and highest volume patient populations. Now this may be counterintuitive to you. Why? Because it doesn't seem safe, right? If you're starting with your most important patient populations, you have a larger risk of failure, but you also have a greater commitment of all your stakeholders in that process. Your purpose, your reputation, all these things that people believe are important to your organization are front and center, and they become success factors for you rather than problems that could deter you from that. You'll have more benefits coming out of the program when you take your biggest populations, your most important populations, the ones that your reputation risks. You'll attract resources to it because everybody will be engaged in it. If you have a hospital partner or specialty partners, they'll want to play in this game. So you start with the big jump. You don't end with the big jump or work up to it. You start here so that you can have real wins that can go forward and convince others to get on board with the rest. Second tip, include both primary and specialty initiatives. Well, why? You can't start with just primary initiatives because the specialty part of your costs are so big that it's really difficult to ignore them. They're 40 to 60% of costs. In some cases, they're higher, depends on your population, and you need both your primaries and your specialists at the table if you're really going to seriously discuss how you can use data and how you can get everybody on board in both arenas, both clinical improvement on the condition side and cost variation on the procedure side. The risk is going to involve both. So it's a brave way of going about it, including the specialists in your beginning shot out of the park on your strategic map, but it's the important thing to do to get specialists on board early in the game. Third, even if you're collecting EHR data right now, or you have a database where you're controlling value-based initiatives, it is really important to put a big push on expanding your data and really ferreting out the value and idiosyncrasies of the data that you have right now. Data is not clean. We've been gathering data from EHRs for over 20 years, and it is not all digital. It is not all interoperable. It is missing in many cases, and it is also miscoded in many cases. So you really have to do a deep dive on the data so that your data is good enough to be able to explain the circumstances that you're trying to do with your initiatives. And you may need a long lead time if you're not gathering enough data, or your data is partly missing, or it's missing from a good part of your, let's say, your specialty groups. Then you will require that lead time in order to do the initiatives that depend on that particular element. Fourth, engaging physicians to lead the transformation is probably one of the most important things you can do. Leading it administratively will never work on the back end to buy physicians in. And that's because what you're really looking at here in the map that we're designing is clinical input. So you'll be looking at care pathways and whether they're adequate and what kinds of things you need to build into care pathways because they are not enough to defray costs that are unnecessary or to make the path straight for as many conditions as possible. There will be clinical pathways development along the way of your strategic map. So it's important to have the clinicians in charge of that effort and lead the transformative process for your entire team. Care teams led by physicians are more and more, they're growing throughout the industry right now and becoming the future focus for practice transformation and transformation focus based on value. And fifth, conduct initiatives that both span the clinical improvement on the condition side and cost variation. Well, why? Because you have the greatest reach, you get into the specialty services, you have a dual focus on patient outcomes and practice patterns, and you will see that coming out in both areas, but it will be much clearer when you're dealing in cost variation that you have a lot of practice pattern issues. And then it's conducive to both the primary and specialty initiatives. So let's talk about these two, clinical improvement, cost variation, the way I've divided them here. The cost savings that you achieve by clinical improvement are a focus on clinical care to improve the patient's specific status. So here you're looking at selected conditions, the highest risk patients that you've been able to glean from the data. your objective to achieve the highest optimal patient status. You may not get patients all the way to the best situation you might like, but it will be optimal for that patient. You'll have a cost objective that is to reduce unnecessary exacerbations, utilization, progression by achieving better control. So it isn't a short path necessarily. It may be, it is shorter than you will experience if you start going down the road of not caring about utilization, because it will just drive your boat. In this case, what you'll do is have a longer term view, but you will begin to see results in patient utilization almost immediately. It promotes the use of treatment pathways for patients. That way you can make sure that everybody is aligned clinically on what is the best, what is the standard of care for the patient. It applies defined interventions. So what are defined interventions? Those are a way if a patient exceeds values, control values in certain areas, they will be referred to a specialist for care or for nutritional services or for these tests, or if they fail on a particular drugs, they'll be referred to a change in treatment, for example. So you can select these interventions very clearly when you start seeing the data and screen for them so that clinicians can review the potential for those interventions and then decide. It involves clinicians, it involves population health, it may involve community providers, it will raise issues of health equity, because a lot of the issues that you will find will be affordability issues or behavioral health issues that prevent patients from getting on an optimal care plan. Cost savings by reducing variation, on the other hand, really starts with looking at the costs and mapping them across the spectrum. So this is specifically for procedure and treatment episodes. By mapping the costs for the same procedure across time and identifying those by patient, you have a comparable unit by which you can compare one case to another case and figure out what the differences is in driving higher costs. And those drivers really drop out of an analysis like that as soon as you start looking. There are going to be things that you can't control, like trauma, for example. You will not be able to control that a patient presented had, procedure X, but was the result of a variety of different procedures. That's an outlier. But it will also identify issues like a poor patient selection for a procedure where the patient had a history of some problems, questionable voluntary procedure that went amok, and then the cost was very high. So it allows you to zero in on issues like, do we have criteria for patient selection? Do we have a pathway that defines conditions where you have an open or a laparoscopic procedure, for example? Do we have policies related to bundling of different procedures and so on in your procedural cost variation? It also allows you to look at some of the clinical things that fall out of a cost variation. For example, complications will immediately fall out. Redos. A patient will have a couple of the same procedures in the same time frame for one different surgical episode, and it will be because there was a redo because the first procedure failed. Those are issues that come out if there is a design to extract different notable observations and refer those back to clinicians for review. Data required on each of these paths also vary. Both of them require claims data, of course, because that's where you're going to get a variety of data that is not in a single clinical record or maybe in 2 or 3 physician's clinical records. On the one side, on the clinical quality path, you're looking for longitudinal data. You're looking for data to show you whether the patient is moving in a positive direction or in a negative direction. That's really important because what you're assessing on whether the patient is on the right path is whether there is improvement or not whether a single value of hemoglobin A1C, for example, or blood pressure is in the right quote range. So you're looking at a variety of different indicators here to, again, define the optimal clinical status for the patient, and all the values, lab diagnostics, disease staging that are important to look at in those different situations. You're looking at prescribed medications. Are they appropriate for the condition? Are they basic, old, fifth tier, whatever? And then referred services for those patients. So those key directly into the interventions that you might come up with to see whether those occurred in the past or not. On the cost variation path, you're looking at a much simpler list. You're looking at claims data, the diagnoses and clinical status, infections, complications, anesthesia, rehab. You're bundling all of the different costs that went within an episodic time frame for that patient, and then you're simply mapping that to determine what the average cost of that procedure was. Looking at the clinical services angle of costs is not without conflict. I think that's probably pretty obvious. Your objective, though, is to identify the risks and events that drive excess costs and then figure out a way through better collaboration, better clinical review, better specialty review, better methods of feedback into a way that is going to improve how care goes forward. Clinical issues are pithy. We know that they're pithy. They can be system issues, they can be different physician issues, they could be a patient issue. And those have to be teased out of the data, and the data needs to be enough to be able to allow that. Just a simple example of perception versus reality. You can be dealing with a group who may have a certain impression of what is going on in their group. Our costs are high because all of the admissions that are occurring are for comorbid conditions. Or it could be that a lot of the admissions are really resulting from treatment. So those are issues that are always going to be contentious going into a data review with any clinical component whatsoever, and have to be definitely approached carefully and make sure that the physicians have feedback mechanisms and that the data is really, really clear to support what the reality actually is. It could be either. Now I want to go into several of the different possibilities that you might have in starting the map. First is to start with a specific patient population. If you started all of your efforts with a specific patient population, your advantages it would be very defined. You obviously know who those patients are because you're identifying them by diagnosis, codes, and history, although there's some danger in that because, as I mentioned, things are not always coded correctly. It can be collaborative because you can round up the clinicians and the staff that are involved in that particular patient population. It can be very goal-oriented. There can be clear interventions. And the disadvantage there, depending on the size of that patient population, is how important is it to the organization? Are you dealing, is there a stake in the success of it for the entire organization? Does anybody care? And is there the data that supports it? let's say instead of starting with the initiative, you are starting with the available data. Here's the data that we have. We're only doing APP reporting, otherwise we just have claims data. And so we are starting with those three initiatives that we talked about in the first part of the series: diabetes, hypertension, behavioral health. So let's say we have just diabetes. The advantages are that when you're starting to look at the data on diabetes values, that it will be data educational to everyone. So if you haven't been collecting data, your clinicians will suddenly see that what you have may be not values on everybody, or that the data may be missing, even though they know that the patient had a hemoglobin A1C. But if it wasn't stored a certain way in the system, it isn't actually being collected. Or it can be missing data, or the patient went elsewhere, or the data could be a PDF. There's a variety of things when you start with the actual available data and look at it to find what you really want to know. You may not have the longitudinal data that you need. It's depending on the format in which you're collecting the data. Not all data, for example, a QRDA1 will not collect longitudinal data. It will give you the latest value of the data. So you won't be able to actually do a lot with that in terms of using it for an initiative that depends on seeing patient improvement. So there are advantages and disadvantages to both these approaches. Again, is if you are looking at available data, have you chosen an initiative that is even relevant to the stakeholders in your group? And so is there a stake in the success? So those are important things to think about in terms of structuring your beginning point. In structuring your data, you really need to look at the entire bulk of your data and see, can our data aggregation support these initiatives to cost? Most ACOs are very new to data aggregation. It has not been a long time that ACOs have been collecting clinical data from EHR. And so cost strategies in the past were largely limited to cuts in some way of one-time expenses. Therefore, a lot of emphasis on cutting unessential sniff days, for example, or bringing patients in who had emergency room use for a follow-up appointment to try to prevent that in the future. When you see aggregated practice data, it's really important that the ACO learn a mechanism to validate and understand that practice data and determine what the integrity of that data is before or through using it in clinical initiatives. Among providers themselves, there's still an understanding of data and data sources that is very early stage. It is not well understood how data that is coming through one kind of format is different than data that's coming through another kind of format, or what the impact is on looking at it in a clinical context. Clinical data is very complex. It is not easy to find. If it's being stored in templates in your EHR, it will disappear into those templates and won't be retrievable through typical means. And so it's tricky. It's not a completely easy way to do it. Understanding of prices, costs, covered costs, patient costs varies throughout the environment, and you need to get on a common lexicon for all of those issues as well. Costs are not the costs that you experience, but the costs that the market experiences. Getting data right will almost certainly need help. You need good data aggregation in a variety of formats. You will not be able to depend on one format because in many cases it won't meet the needs of being able to conduct either quality or clinical initiatives. There has to be excellent patient matching across the sites of care and data feeds. Their capture of clinical information of all types is going to be essential. Ejection fraction. Some of the values that are not stored in typical databases are going to be needed for a lot of different conditions and depended on. Expertise in many physician-based systems is going to be important for you to look for so that you're not relying on a vendor, for example, who only knows how to get data out of a FHIR application attached to Epic. And experience in creating clinically valid episodes of care. And why is that necessary? We dealt with that in part 2 of this series a lot. Episodes of care are the vehicle by which you map both the cost variation episodes as well as clinical episodes to compare patient to patient. Getting the best value of that data aggregation definitely means you should avoid single-use data pulls. Don't do a data pull for one purpose. Make sure that you're aggregating everything that you need in your data for all of your initiatives because it's expensive to go in and get that data. For your APP, don't use limited data formats if you can get by with it because a QRDA will only be specific to a measure. It will give you one measure and one value, and it will not help you actually explore the cost side of things. Survey practices on their EHRs try to identify your issues in advance, and hopefully, in the last initiative here, consider getting a central or reducing the number of systems that you really have to deal with so that your physicians are not on archaic systems. Data limitations degrade the opportunities you have in a lot of different ways. How old it is, what kind of source it is, and how that limits its content, how it's trended over time, how it's old, poor, doesn't have patient risk information in it, it can't be interrelated with clinical data, so on. So one other thing I want to go into on the data side is what are the cost analytics you need to do if you want to do any of these cost control, data-driven cost control. First of all, episodes of care. What are they really telling you about the conditions and procedures? They're telling you which patients are in poor control, what the cost is of your exacerbations, your utilization events, what comorbidities those patients have. If you're tracking it, of course, you have to build the episode to be able to do that. You also have to build multi-clinical comorbid conditions so that you can have episodes that define a severe risk group of a variety of different conditions. Patients with no improvement at all. If you're seeing patients that are on a flat line of chronic condition outcomes, then that should be a signal that there is nothing good going on here. The patient is on autopilot either by the patient's determination or because the clinician has checked out, not believing that the patient can improve. So that's a red flag as well. Variable procedure costs by condition and by cost driver. Avoidable costs by episode should be part of the analytics that are coming out. Expected versus actual treatment in care pathways for chronic conditions. You should see these. You should see certain referrals. You should see drugs if they're part of your care pathway. You should see a variety of diagnostics and so on. You need to be able to measure the cost effectiveness of your changes in your pathways and in your interventions. If you can't measure them, then what was the point in actually doing them? Because you won't know whether you made any difference or not. So that's a very important analytic for you to do in the cost side of things. And then, of course, because we're talking about moving from value-based care payment models or from fee-for-service into value-based care payment models, you need to be able to model those payments against not only the cost of providing care, but against your historical fee-for-service cost. I want to speak to a little bit about ways of targeting interventions in your program. Well, first, you are almost always going to be targeting by the big three metabolic conditions: diabetes, hypertension, and coronary artery disease. You'll almost certainly need to target interventions for heart failure patients, make sure that they're on the 4-pillar controls. Patients with static outcomes, as I mentioned, a big target, and prescription drugs on the lower or older tier so that the patient is not improving in combination with static outcomes. And then both high and low procedure costs, because on the low end, there's something unusual that is either good or not good. You'll have to evaluate. And on the high end, the same. So you always want to target your interventions on the extremes of those for sure. So a wrap up of this little owlet, I couldn't resist. So 3 themes. 1, value-based payment models are expanding. They're going to risk. They're primarily going to capitation or a per patient, per population review, however you want to, whatever you want to call it, it's the same thing. It's capitation. CMS is increasing cost measures for non-APM providers. A lot of those cost measures are going to be showing up in the APM providers. They're already showing up in some of the models right now. They're showing up, for example, in the specialty care models. They will be showing up, I'm sure, for the ACOs. They're vastly expanding under the MIPS program every year. The specialty care models themselves are expanding too. You've got the enhancing oncology model. There's a lot of discussion of the other models, and CMS has said specifically that they're going to be expanding these. So I think we can see that coming. So that's theme number 1. The data availability for all of these initiatives is really just growing fast. ACOs have to rise to the challenge of aggregating this data. It's still early stage at this point. There are administrative effort or methods of lowering cost and coordinating care, but they don't have the power to create enough cuts in the total cost of care and the total per capita cost. Why is that important? Well, because right now we are touching just a fraction of costs in Medicare, and as the budget crisis continues to grow, that will become imperative. So there will either be cuts in services or there will be cuts in costs. Clinical cost initiatives are necessary, so you really can't transform the outcomes unless you're both looking at costs and the clinical components of these programs. So this is where it's at. And the time for development right now is the time. The data, even if you were looking at just gathering your data starting in 2024, you could create fledgling initiatives in 2025. You might expand them over a couple of years. It would definitely take you 3 years to do a really good expansion of those programs. You might get real results 2028 and beyond. That's a long time. Is this realistic for your bottom line is the question you really need to ask. And that wraps it up for this program. Just want to give a little credits to my dogs, Mac, Pippi, Tane, and Nika, for contributing their time and talent to help this education along. And then we
Those
have
dogs
questions.
love value-based care.
They really do.
um, we do have some questions that have come in. And by the way, if you have a question, go ahead and ask it now. You can use your control module there. There's a place to ask questions. And we're going to get to as many as we can. I think we got some time, so we should be in good shape here. Uh, First question here is a lot of ACOs have generated big savings without having to do complicated data gathering and cost initiatives. How do you explain that?
I explain it by the one-time cuts, and and any attention to costs is a good thing. But it has, even though they've been large for some individual ACOs, they have not been very large or large enough for the Medicare program. So the only way to get at that is to go to the next step, which is now we've got the early grapes picked. Let's start going after the real clinical problems.
Okay. Next question here is pursuing the kind of clinical cost initiatives that you describe seems to require more analytical expertise than most ACOs have. How can a typical ACO accomplish this?
Well, most ACOs are not going to have the depth to be able to do this on their own, and I wouldn't expect they would. They're all going to need somebody to aggregate and be an analytical partner in order to do this stuff. Just like they need a registry to do reporting for their quality, they will need somebody to finesse the data and be responsible for that. And it's not an overwhelmingly expensive thing to do. It can be very cost effective to have them do this. So they will need help.
Yeah, very good. And a follow-on question to this is if we would like to do something along these lines, what's the good starting point?
Well, you start with, I think I mentioned several different starting points in here. I think you can start with the patient population. You can start, like I suggested in the very first webinar, using the APP reporting data and using diabetes and hypertension as a patient population to start, because you've got some data to do it. But in the meantime, ACOs need to be aggregating the data to do a much more in-depth quality and cost initiative basis for their patient population. If we're going to solve the cost problem, we're going to solve it by improving the clinical status of patients and getting them in a better situation where we don't have excess costs. So the real answer is let's get rid of excess costs before those costs occur. And you can do that with the clinical data.
Wonderful. Next question here is can AI be an effective in analyzing clinical data, and what are some of the example use cases?
AI will be able to be effective if the data is good. The problem right now is that the data is not good enough to be able to deploy AI effectively. It's not even enough to do the machine learning that is necessary to do AI. And so people who have looked at clinical data, for example, I mean, in the clinical world, not in the value-based care world, but in the clinical world, looking through radiology exams and assessing tumor, there's so much more data. Looking at the ACO world, where you have a finite patient population, you're not going to have the depth to do the machine learning that's necessary to understand a lot of the risks. That is going to take larger populations and a lot more data and better data over time. So unless an ACO or an organization has a multi-year, and I'm talking a lot of years, multi-year database that would allow them to see all of the different values that you need to diagnose various issues. They won't have the support for an AI now. Will that happen? Absolutely. We're working on it right now. We're identifying exactly what data fields that we need to do better in all of the different chronic diseases, at least those that are the most populous, and cost variation as well. But I think value-based care is still early stage on this.
Yeah, I would agree. So we actually that concludes the questions that we had come in. Unless one comes in here in the next couple of seconds. This is great. Terry, thank you so much. This was a wonderful presentation. If, by the way, you do have a question and you think of it later and you want to submit it, feel free to reach out to us. We're going to tell you about how to do that right now. As we close out here, I wanted to encourage you all to head over to vbcexhibithall.com and check out the Roji Health Intelligence virtual exhibit booth there. Which is a really cool resource that's got a lot of neat information about them, and you can read up on what they're doing in the space and kind of keep tabs on them and some of their resources. Highly recommend you look at it. They've got a lot of great information for you. And then finally, if you would like to reach out to them directly, feel free to do so. Their information is here on the page. You can reach out to Leonard or Terry, and they will point you in the right direction. And will help you out, or feel free to reach out to me as well, and I'm happy to facilitate an introduction if that is easier. But again, I wanted to thank you all so much for joining us today. Terry, as always, thank you so much for a wonderful presentation. We're going to be sending out an email soon that's going to have a link to the recording as well as to the slides that you can download. So hope that you will join us again next time. Thank you all so much for coming. Bye-bye.